Welcome, everyone. Today's topic, it's very obvious what we're speaking about, but just to lay some groundwork, maybe at the onset, give you some perspective to think about, some things to chew on as we move on. COPD, I know we're probably all familiar on the call with COPD to some degree, but the definition has changed over recent years, and they have some nuances that they add in on the guidelines. And as we go through, I trust you will appreciate them more. But COPD is a common, preventable, and treatable disease, and it's characterized by persistent respiratory symptoms. In other words, it can be treated, exacerbations can be dampened, but they really never are completely eliminated. And so not only do the patients with COPD have respiratory symptoms, but airflow limitation as well. And they're due to several abnormalities, as we'll go through today, usually caused by a degree of exposure to noxious particles or gases. And if you think about, irrespective of the area of the country or world in which you live, we are exposed to particulates, foreign matter, and debris everywhere that we are, whether we're indoors or outdoors. So just leave that as your reference point moving forward. I have no conflicts of interest to report, although certain products, devices, and medications will be discussed within the scope of COPD management just in general. Just to be clear, I'm a respiratory therapist, not a medical doctor. Hopefully, all on today's call can utilize the information presented, though, regardless whether you're an RT, an RN, physician, pharmacist, any other healthcare provider, just a student maybe that is on the call. Hopefully, this is usable material. I'll give you the most current data out there and hopefully spark some interest and maybe a deeper dive for some of you to take it further. But particularly for those with COPD, it is complicated. Not only for the COPD manager, the clinician dealing with a patient that has COPD, but it's of course taxing more than any person. It's going to be taxing to the patient and of course the family members, their loved ones. And we'll touch on a bit of that today as we move on in the later portion, looking at the case studies. So just simple objectives today, 3 simple objectives to keep us on track. We're going to identify the purpose and goal of the guidelines. We're going to discuss assessment and diagnostic aspects of the disease itself. And we're going to categorize patients according to these new guidelines that just came out later last year. And we're going to touch on some treatment strategies for both stable and in those who are exacerbated. Stable COPD is not too different than most chronic diseases when they're well controlled. They should be minimally asymptomatic, but still with COPD, as the name implies, it is a chronic obstructive pulmonary disease. In other words, it does not go away. So this is the most recent comprehensive document, updated 2023. It has now grown to over 200 pages, 205 to be exact. They offer a more concise summative pocket guide that's about 55 pages, and I recommend downloading this document. If you are a COPD or a pulmonary disease manager of any sort out there, I would recommend that these guidelines are very familiar to you. And again, the 55-page version, the summative version, is probably more feasible to keep abreast on. To give you a bit of perspective, the so-called Global Initiative for COPD, also known as GOLD, it's made up of a board of directors and a science committee, as well as what is known as a GOLD Assembly, which includes leading physician scientists from various parts of the world, researchers, and clinicians alike. So the GOLD group revises their report each year as a tool with the primary purpose to provide what they're saying is a tool to implement effective management programs based around local healthcare systems. So they're aware that things change from time to time. And what you'll see coming up is just a few changes here and there, but nothing too dramatic has changed, to be really honest with you. According to goldcopd.org, this is the website that provides the world-renowned GOLD guidelines, the Global Initiative for Chronic Obstructive Lung Disease. They work with healthcare professionals and public health officials around the world to raise awareness of COPD and to improve prevention and treatment of this lung disease. Now, with COVID, and I won't bring this up too much because that's not what today's about, but with COVID pandemic, we lost a little steam in the world of COPD because it actually went down in ranking as a leading cause of death in America and the world. It was projected to be top 3 for quite a while. Of course, COVID changed everything. But through the development of this evidence-based strategy document and documentation surrounding this document for COPD management and events such as the annual celebration of World COPD Day, this organization known as GOLD is working to improve the lives of people with COPD in every corner of the world. At least that's their overarching goal. So you can see from this bulleted list, the GOLD guidelines serve several purposes. Arguably, the most important in this list maybe is number 3 here. As you can see, shown to decrease morbidity and mortality. I mean, isn't it about dampening the disease process or the manifestations thereof, or absolutely preventing early death? That's the goal of any disease manager. Mind you, so-called programs can be just about anything that is implemented to be effective in decreasing disease burden, just heightening awareness overall, and certainly adequately treating patients to prevent exacerbations. That is the key. And you can see the fine print down there directly from the guidelines, and I'm quoting here. Their goal is to, of course, provide non-biased review of what evidence is currently available. And the last step here, the last bullet, implement effective programs to prevent COPD. It is a preventable disease. Not all who smoke will acquire COPD or develop COPD, and likewise, not all those who have COPD have ever smoked, even though smoking is a leading risk factor, which you all are very aware of, no doubt. You can just Google Gold COPD or go directly to their website, goldcopd.org, and you can quickly download these PDF versions. One that I would recommend at your disposal is the entire report. But once again, there is the pocket guide, backing up a moment here. So you can see also there on the web pages that are shown here, the web page snapshot, that there's an annual Gold International COPD Conference, and it's usually in Philadelphia, Pennsylvania each year. And there's also an official COPD Awareness Day, which falls on November 15th every year. There are many other resources among their web pages aside from just the pocket guides and summaries. One, if you are an educator or one in bedside training role in your current occupation, you may want to be aware they have PowerPoint slide sets, and they even have an app. There are even podcasts available if you really want to nerd out. I mean, do we need another podcast? Well, sometimes you know how the flow is. You're in traffic and you want to pick up some good information. They do have podcasts available. So we will concentrate primarily for today's topic on the most updated report from 2023. Worth emphasizing, one of the most important things to note is the definition has changed. This will, of course, inform a majority of everything else in the report. Also, this last year's current update includes a new chapter. As you'd likely suspect, we now have a Chapter 7 for the first time, and it addresses, as you see here, COVID-19. A bit later, we'll dive into the so-called treatment objectives, which is really what steers everything once a diagnosis is made. So here is the latest global definition of COPD. And according to the latest Centers for Disease Control stats, chronic lower diseases, chronic lower respiratory diseases more specifically, mainly COPD, believe it or not, is currently just the 6th leading cause of death. So it's been bumped down, a lot to do with COVID, of course. Just under 5% of adults in the United States have ever been diagnosed with COPD, even though you and I in our current profession, likely in our daily routine, because we are exposed to so many patients with COPD, it seems maybe more common than it is, but it's still a staggering statistic. I mean, just under 5% of adults in the United States, that's a lot of people, have ever been diagnosed with COPD, and let me specify, including emphysema or chronic bronchitis. I mean, this is staggering. More than 140,000 Americans die of COPD each year. That is about 1 death every 4 minutes. Just since we started this talk, more than 2 people have died of a COPD-related condition. The main risk factors are tobacco smoking, indoor-outdoor air pollution, and occupational exposures. There are a variety thereof. So in the new definition, in the GOLD COPD report, the guidelines that we're speaking of today, you can see that there is emphasis on bronchitis and emphysema. Not that it has not been emphasized before, but it's being renewed, if you will. So chronic obstructive asthma is not mentioned, and that is a real clinical condition that you see out there for sure. So although this definition is verbatim from the new 2023 Gold COPD report, its original release was in the American Journal of Respiratory and Critical Care Medicine in 2022, and you can see it here. So the Gold Science Committee prepares these updates to the document each year. They're made available on the COPD Gold website as they are completed. And the Science Committee uses a sophisticated set of procedures to review the world's literature, and I do mean on a global scale. I'm part of a clinical practice guidelines committee currently with the ARC, and it's very meticulous. I cannot imagine being part of a committee that has to look at global publications on such a broad topic. I mean, we're talking thousands and thousands of articles and publications. And so what their goal is to take it, conglomerate, and update the documents to reflect a state-of-the-art body of information. And of the changes in the new report, again, the updated definition is of paramount importance to steer everything else. However, a lot of new information, not just revision, is included in the latest iteration. And I've teased out the main items on this slide and the next few to come. So be free to reference these, and hopefully you can go back and look. I know Mr. Barnes has made the slide set available to all the listeners out there. So Chapter 1, rewritten to incorporate these new strategies for terminology and classification. I know this is the things that makes the students go nuts, right? They have to figure out what category, and then you treat accordingly. After you've been doing it a while, you figure out that, we really don't see a lot of the in-between as much as we do the mild and then the most severe cases. I would say sheer numbers-wise, certainly you see the middle ground as far as the classifications, but the ones that we're most interested in effectively treating and those that we are trying to prevent acquiring later stages of the diseases are the two outliers, the lower limit of disease and the upper limit of disease. So this Gold Science Committee, they prepare updates to these documents every year. Here are a few more. Notice inhaled medication and delivery is now addressed in detail in the report. I mean, that has respiratory therapy written all over it. Also, telerehabilitation, basically virtual pulmonary rehab from their home, is now officially endorsed in the report. That should make some of you excited out there, particularly those that do telemed already or home care. And this rehab isn't just considered phase 3, where at-home self-management or maintenance would usually occur. The committee is recommending creative approaches to phase 2, where outpatient attendance isn't feasible or likely. And the new table on diagnosis and assessment is coming up, and I'll display it here in just a few moments. So here are a few more. Chapter 5, expanded management of exacerbation topics, and new table on diagnosis and management. Again, these chapters, they seem to be daunting at face value, but it's a very concise overview of not only the need to know, but the nice to know surrounding COPD management and care. As expected, I mentioned earlier, there's also now a completely new section that addresses COVID-19 and COPD. Now, all of these changes to the Gold COPD report is a result of mainly the committee's updated literature review centered upon emerging research. Also considered is the overall healthcare cultural changes across the board. I mean, we're doing healthcare much differently than we were just a few years ago. I won't say the C word again right now, but it's definitely different than it was pre-2020, let's say. If you're a respiratory therapist or any healthcare provider on the call today, you certainly see patients presenting with symptoms of shortness of breath. They have a cough, an increased sputum production. A chronic cough is usually defined as a cough that lasts for 8 weeks or longer. With COPD, particularly moderate to severe or end-staged, a persistent cough and recurrent exacerbations are unfortunately a part of the patient's life. I won't say daily routine, but it's very rare that someone with end-stage COPD, even moderate to severe, has a normal activities of daily living. Their quality of life is certainly impacted on the negative side. And they have this, it seems, almost waiting in the wings infection or exacerbation, waiting to be realized. And I think we all can agree that we understand what a frequent flyer is. They come into the ED, they end up sometimes on the floors, but mainly the ICU if they're in a deteriorative state. And you get to know these patients and you form this bond and you really want to help where you can. And hopefully today I'll give you some information that will help spark not only a desire to do even better than we're doing, but the latest data that's available. So the main risk factors for developing COPD are shown here. You can see tobacco smoking upper right there, tops the list. And genetic predisposition is still a likely cause, although many years of research reporting suggests that an individual effect size that is quite small for genetic predisposition and predictability of developing COPD. So we know there's a genetic component. We don't know the impact thereof. And it's very uncommon for someone to have genetic testing that elucidates this idea that, yes, you have a genetic predisposition for, lung disease, for obstruction, for disease severity. Now, certainly there are certain ones that can be, deduced early, alpha-1 antitrypsin, cystic fibrosis, some of the others, but they're still unsure what really predilects someone who has only smoked a half a pack a day intermittently for a few years to develop, spirometry that looks severe versus someone who, I remember this man in particular, smoked 3 packs a day. He was very proud that he had started smoking as a teenager and he was in his 70s with very little symptomology. And he was right. His spirometry was almost completely normal. I had never seen that and haven't seen it since. So there's this relatively new way of viewing the COPD condition in that, as shown here, patients with COPD-like respiratory symptoms but without airflow obstruction should be labeled pre-COPD. The term PRISM is something fairly new. It's known as preserved ratio impaired spirometry. And this PRISM term description has been proposed to identify those who have a normal ratio. In other words, their FEV1 to FVC ratio, also known as FEV1%, is normal, but overall their spirometric results still fall below the lower limit of normal for your flows and above the upper limit of normal for your various volumes. Now notice, although patients that fit this so-called pre-COPD or PRISM criteria are at higher risk of transitioning to a full COPD diagnosis, not everyone worsens to that degree over time. So let me be clear before we move forward, spirometry is an absolute must when attempting to diagnose, to classify, and manage the COPD condition. And aside from clinical history, spirometry is one of the quantifiable metrics to allow a definitive COPD diagnosis because so much else is subjective, right? A patient's perception of shortness of breath is, we call it dyspnea, but someone can be stressed, can just be, difficulty sleeping for a week, not eating well. They come in, don't feel so good, and oh yeah, I'm short of breath, I'm just deconditioned. And that doesn't have anything to do necessarily with COPD always. So there's a lot of variability in the subject assessment. However, spirometry is what we call the gold criteria. If you want to say literally and figuratively, it's the gold standard still for diagnosing COPD. And to that point, you can see that COPD patients, as expected, have indication of airflow obstruction on simple spirometry with a FEV1 to FVC ratio, also known as FEV1%, less than 70. You can see here at the top, that is the most important initial point of view that allows you to, with confidence, suspect this patient may have COPD. Now, there's a lot else to take into consideration. Notice this is a post-bronchodilator, by the way. Recall that certain obstructive diseases such as asthma are fully reversible, but true COPD is only partially reversible at best. Forced spirometry is still considered the most reproducible and objective measurement of airflow obstruction. That part has not changed. So a reminder of the main goals of COPD assessment. Ultimately, a diagnosis must be established first. And thereafter, of course, an effective treatment plan is the ultimate goal. We have to identify what is present and, of course, treat accordingly. You can see that therapy is going to be guided by the COPD assessment. So how severe is the airflow limitation? Step one. And then we're going to look at the entire clinical picture. And the hope is that we can predict the risk of future events and prevent those events. All the above are meant just as a guide. Of course, you may know the patient more than the other caregiver, and historically, it's very important to understand the patient's course of care, although some patients are poor historians in recounting and recalling what all they've encountered. There's an oxygen deficit over time that affects the brain and long-term memory. But again, very important just to have a starting point, and that begins with proper diagnosis and classification. Yes, smoking is a main risk factor. That certainly is true. But when best described per the GOLD Expert Committee, COPD is influenced by both genetic and epigenetic factors. Epigenetic meaning how your environment influences the manifestation of disease. Certain things can be turned on and turned off in your genetic code according to what you are exposing yourself to. And patients need to understand if they're in an environment that is toxic. I know the young people like to use that term quite loosely these days, but if they're in a literal toxic type environment, if they're not removing themselves or have an ability to remove themselves from that environment, it's going to be very difficult, if not near impossible, to prevent greater worsening of the disease and concurrent exacerbations. So COPD is influenced by both genetic and epigenetic factors, and not everyone that has COPD has smoked, again, and not everyone that smokes will get COPD. Most will likely develop obstruction if they smoke long enough, but some of the most severe cases of COPD I've ever seen have been non-smokers. I'm not saying it's more common, but some of the most severe cases. Typically, it's genetic predisposition, chronic exposures to particulates and irritants, and it's just a really sad condition when patients end up from a job occupational exposure with a severe COPD. Genetic predisposition is not always easy to predict, but it's powerful and impactful to disease development when it's present. So all of these comorbidities should be actively sought out and treated appropriately when they're present. All of these can influence mortality, their lifespan, life expectancy, and their hospitalizations independently, as well as their overall health status, independently of the severity of their airflow obstruction due to the COPD. And you've seen these over and over. Think back to your patients, you that have been doing it a while. Think back over the years, how many patients you've seen with COPD that have every single thing, if not all but one, on this list. And it just becomes almost like a menu at a restaurant you're used to visiting. You expect to see the same things on the menu, right? You see this over and over with our COPD patients. It's no surprise why they are scared to do things to try to increase their activities. There was a saying years ago, I don't remember if it was American Lung Association or maybe ARC, but every breath counts, and if you're not breathing well, nothing else matters. It's so true. So here is shown what is known as the MMRC, the Modified Medical Research Council Dyspnea Scale. Now, this is a patient self-rating tool where they're going to, their own perception, it's subjective. How do they feel? They're going to check the box. So it's from their point of view, where the goal is to assign a number or grade category to both qualify and quantify a person's breathlessness during day-to-day activities. So it's from their point of view. It could be viewed as a surrogate for indicating even quality of life or implying a level of activities of daily living with or without breathing difficulty. I mean, this is very simple, 0 to 4, but it gives you immense insight into what the patient is experiencing. It's a simple tool that scores either 0 for everyone, no doubt. I would get breathless with strenuous exercise, surely. 0 represents breathlessness only with extreme activity, and then a 4 would indicate, as you see here, being too breathless to even leave the house or getting dressed. You're breathless. You can't do normal activities. I've even had some patients, sad enough, complain they're not able to maintain good hygiene. They're just so short of breath doing normal bathroom-related activities, shower baths. It's really, they're in dire straits near the end stage of the disease. You can see from the citation included here that this test has been around for just over 40 years, but it is still endorsed by many professional organizations, including the latest GOLD COPD guidelines. So to prevent some confusion here, that reference from 1982 is the original, But what you're seeing here, the graphic is from the latest 2023 iteration of the GOLD guidelines. So an oldie but goodie. Here is shown the COPD assessment test, also known as the CAT assessment. This tool attempts to qualify and quantify the degree of happiness or sadness centered upon overall symptomology. And you may say, I'm a clinician, I'm right-brained, I'm all about taking care of the patient, looking at the data, the numbers, treating the symptomology, but there's so much more to it. And you that are more, I would call, not as rough around the edges, more astute, more in tune with your patient's overall needs holistically, which that makes the best clinician, by the way, that's a freebie. You should be in tune with some of this stuff. Notice the scale from 0 to 5 for each question with the total possible score from 0 to 40. So the higher the number, the worse the patient's condition, just like the MMRC test we just looked at. So this CAT score is also known as a COPD impact score, where anything 10 or above considers COPD to have greater than just a low impact on the patient. So if they're scoring 10 or above, they have a significant burden of disease. Both the MMRC and CAT scores are accounted for on this more, what I consider an all-encompassing tool known as the newly updated ABE assessment tool. An iteration of this tool was originally presented in the 2011 GOLD update, so it's been a minute, but they brought it back. So the ABE tool offers a model for the initiation and the steering of pharmacological management of COPD according to that individual assessment of symptoms and exacerbation risk that we just mentioned. You can see on this tool that spirometry results are included in order to grade from category GOLD 1 to category GOLD 4. So the higher the number on all these tests, as well as the higher the number on the GOLD category, the worse the condition. So the Modified Medical Research Council dyspnea questionnaire, known as the MMRC, and the CAT, you're going to see more and more of this at bedside. As you know, latest released research and publications take anywhere from 3 to 5 years to usually arrive at bedside, especially if you're at a non-academic medical center. So be the champion for your institution on this. The CAT test, by the way, the COPD assessment test, is not too different from the St. George's Respiratory Questionnaire. It's just a lot less elaborate. It's very concise. So the St. George's Respiratory Questionnaire, even though I'm not showing it here, it still remains the most widely documented comprehensive measure. But you and I both know if you've used this, it takes a while to implement this SGRQ. So here's a short list of updated recommendations to maximize COPD patients' quality of life. I want to particularly call out that despite various low-level articles that might discuss e-cigarettes as a tool for tobacco smoking cessation, page 12 of the newest GOLD guidelines, and I'm going to quote it here, it states that there is no evidence, let me repeat, there is no evidence to support the effectiveness and safety of e-cigarettes as a smoking cessation aid at present. As expected, vaccinations are still recommended, as you can see on the list. And even though vaccines in general have become a particular hot topic as of late, and maybe even controversial, per consistent research findings, both flu and pneumococcal vaccine do show they decrease incidence of lower respiratory tract infection. And you that are working in a clinic alongside the pulmonologist, maybe we have a pulmonologist or two on the call here, certainly we're still recommending the flu and the pneumovax, as it's known, vaccines. Just some additional considerations included in the updated recommendations, the current guidelines, in order to maximize COPD patients' quality of life. Long-term oxygen therapy, known as LTOT, has been shown to improve survival. In other words, to lengthen life for patients with severe resting hypoxemia. This is patients who live at a P little AO2, an arterial partial pressure of oxygen, less than or equal to about 55 to 60 millimeters of mercury. Or if they have cor pulmonale, if they've got right-sided heart failure or secondary polycythemia. So your so-called template or by-the-book severe COPD patient, besides quitting smoking, long-term oxygen therapy is one of the few things that has been shown to actually increase length of life. Now, I argue it would also increase quality of life, but That's left to the interpretation. So for patients with severe chronic hypercapnia, where they walk around with CO2s 50s, 60s plus, and a history of hospitalizations for acute respiratory failure, long-term non-invasive may decrease hospitalizations and prevent rehospitalizations. And then there's these select patients with advanced emphysema. We know that's a type of COPD that are refractory to traditional therapies. Surgical or bronchoscopic interventions may be beneficial. And some of you are seeing these out there where they're putting in splints, one-way valves, a lot of things on the market currently. So remember, goals for treatment of stable COPD are going to be to reduce symptoms and to reduce risk. Now, research has suggested a majority of patients that actually want to quit will most likely require multiple attempts to quit smoking. In other words, some research suggests even more tries than 5 to 7 times. And I was on a webinar. It was put on by one of the Ivy League schools, and we were very excited. It was an expert, worldwide expert, and it was one of the webinars you could join in. And the long story short of it was, the summary was most patients, it was upwards of 80% plus, that smoke actually expect their healthcare provider to address their smoking. So even though you may get some attitude, it may seem offensive at times, they actually have an expectation that you should at least bring it up. Appropriately, but bring it up. And we know many will need help, such as nicotine replacement therapy, in order to quit smoking. Again, management strategies are not limited to just giving medications. There are lots of non-pharmacologic interventions to help manage COPD, breathing exercises. There's some others that are more holistic that are beyond today's topic. But goals for treatment of stable COPD, remember, reduce symptoms, reduce risk. So without going into the extensive therapies and multiple charts that guide medication use, here are just a few summative points. You'll notice that single medication use, also known as monotherapy, is inferior to the use of combination medications. More is better when you're trying to get a synergistic effect of medications. And now we even have combo meds that are 3 deep. Although it is recognized that single inhaler therapy may be more convenient and therefore more effective and certainly more affordable many times because of availability and compliance than, say, combination therapy. Theophylline is only known to exhibit a small bronchodilator effect in stable COPD with only modest sympathetic benefit. I should say modest symptomatic benefit as well. So PDE4 inhibitors, which I know have been on the market a while, but may not be as familiar to some on the call here. They're used in our local area, but I remember when they hit our market and everybody said, why are we giving respiratory therapy patients a Viagra? But these PDE4, these selective phosphodiesterase inhibitors, they have anti-inflammatory effects. And part of that is they suppress the release of cytokines, which, if you recall, cytokines are chemical messengers in the inflammatory cascade. These PDE4 inhibitors also prevent neutrophils from infiltrating the lungs and prevent other leukocytes from gathering to that area. So pulmonary remodeling and mucociliary malfunction overall are attenuated with the use of PDE4s. And I suspect we're going to see more and more in the literature in the coming years about PDE4s. So for chronic obstructive pulmonary disease, just summarizing here, the PDE4s, the phosphodiesterase 4 inhibitors, are used in the treatment of severe COPD to reduce the risk of exacerbations. They are not bronchodilators, and they're not indicated for the relief of acute bronchospasm. Let me make that clear. So today's topic is not meant to produce a comprehensive dive into COPD treatment and pharmacologic interventions, but worth mentioning, so many more medications, aside from traditional bronchodilators, may be indicated or optional dependent upon the patient's current state or their symptom history. So there's a lot more options today than there were 10 years ago. A lot of the same medications are still around, but what we're seeing is more layering. And you that have been in the clinical arena a longer time period, you've been privy to see that historical progression from an inhaler, an anti-inflammatory, or I've got my 2 inhalers and I take a breathing treatment with the neb every once in a while, to now they're on, a triple medication, maybe an additional inhaler, they take a capsule, and, they take something else. So we're seeing a lot more layering. Look, I realize it's a lot to take in and it's kind of small on the screen here. There's no need to memorize the chart. And to my knowledge, there's no test on the chart at the end. But the reality is that physicians or mid-level providers will be managing the therapies and ordering the various medications, but the respiratory therapist, and in some cases nurses, will be administering the medications. So you can see from this relatively comprehensive list, many options exist, and likewise, many formulations and therapeutic devices therefore exist. Not only is it confusing to the healthcare provider, but you can imagine to the patient that does not have adequate healthcare literacy. And they're overwhelmed and they're not feeling good. And many times the only opportunity you get is right before discharge or at the end of their outpatient visit where they're tired and they've been NPO for 12 hours and they need to use the restroom, and you know the situation. So to put it into perspective, this is just a sampling of the inhaled medications currently on the market. I mean, this chart provides great insight into the complexity of respiratory care for any patient population treated with inhalers, but could also be considered particularly relevant for the specific COPD patient, as a majority of these medications are also used to treat COPD. No doubt we've all seen charts similar to what is shown here. It's no wonder that patients and caregivers, and let's be honest, even bedside clinicians, are oftentimes confused on the what, the why, the how the heck do we deliver the medication properly? And if they're on more than one or two, what's the correct sequence for administration, right? Am I speaking your language out there? But how did we get here when things started out so simple? Well, we have more information. 2023, the AARC, American Association for Respiratory Care, published their 5th edition of the Aerosol Delivery Devices Guide. And this is no doubt an exceptional resource for any clinician wanting to increase their expertise in order to better educate patients. By the way, this is readily available on their website in PDF. You can download it, and I think you should have it at the ready. Also, most manufacturers make their package inserts readily available for viewing or download online. You can occasionally have it on your smartphone. There's apps now, especially in outpatient care. When you come across a less familiar aerosol device, or the drug rep brings some samples, or there's a new medication that hits the market. Certainly there's many on the market already, but a plethora of newer devices has seemed to emerge over the last decade or so at an accelerated rate anyway. But a great resource here. Remember goals for treatment of stable COPD back to reducing symptoms, reducing risk. So here are just a few items of interest that were called out in the most recent GOLD update. I did the work for you, so you don't have to. It's a lot of pages to read, 205 pages, but I'm teasing out the good stuff. Notice the levels of evidence are shown in parentheses at the end, A being the highest level of evidence. So we've got some things that were not necessarily as commonplace as they're going to be in the years to come here. There's no conclusive evidence of a beneficial role of antitussives in patients with COPD. There's two ways to think about it. We suppress the cough, or do we allow expectoration? Sometimes coughing can end up in a spasmodic sequela where they're more exacerbated after coughing something up than they were prior. So there is a different way of thinking. I'm not saying leave the secretions in place and let them pool and conglomerate and create an abscess or a resident infection, but there's lots of ways to look at it. Regular use of mucolytics reduces the risk of exacerbations only in select populations. So despite all the advances in technology and emerging data related to the so-called biochemical influence over the COPD condition, pulmonary rehab remains a simple yet effective intervention. I am team pulmonary rehab. Notice that pulmonary rehab time, and again, has been shown to improve health-related quality of life overall and to actually decrease hospitalizations. The real barrier is the buy-in at some institutions because it's not always a big moneymaker. And it's difficult to prove that you prevented something that never occurred, right? You can't prove the null hypothesis. It's sometimes a difficult selling point to say, I saved the hospital so much money and my patients so much pain and suffering by preventing something that never happened. So here's a summative slide from GOLD COPD. As with any therapy or intervention, a proper, accurate diagnosis must be assured to start. That is always the first piece of the puzzle. When you're putting a puzzle together, you need to know what the picture should look like to start. Well, with us, we need to know they for sure have been diagnosed with COPD so we can take them down the algorithm of care. Thereafter, we classify and categorize. That should be established early. And you can see the initial management section here includes the key items we've just overviewed. The CAT score, the MMRC, their history, if they are not poor historians and can recall such. So there's so much to consider when caring for a patient with COPD, particularly when in-servicing the patient for the very first time on a new inhaler. We've all been there. Or whether it is the 100th time they've used the device. They are complicated, right? It's complicated. And so we have a big responsibility. I'm highlighting education and training, not only for the clinician prior to getting out into the market and taking care of someone's family member. We have to think about our patients as someone's favorite family member, and we'll care for them with great kindness. We have to take a bit of time whenever possibly to truly assure our patients that they understand not only the indication, but the proper administration technique. We've got to garner buy-in. It's so important. Sometimes buy-in for one patient means giving them the hope that they're going to breathe better and be able to take care of themselves better. Buy-in for another patient, for example, might be you're going to be able to potentially go out in public and walk from your car to the store and maybe do your own shopping. So everybody has different goals, but garnering that buy-in, you have to center in on what makes a difference for that person. And that's when we put our clinician's hat on thereafter and figure out how can we get them to that point. So a few more items of interest that may not always be front of mind, but important nonetheless. Diuretics. Now, these are adjunct therapies, not frontline. We see quite a few patients that are fluid overloaded. If you've got breath sounds that are crackles and your chest x-ray is whited out and you're not putting out as much as you're taking in, certainly we've got a problem, right? Anticoags, not necessarily just as a so-called blood thinner, but we have a lot of patients that part of their pathology of chronic inflammation is microclotting. And you've seen the chronic atrial fibrillation that our patients often have. Right-sided heart failure is a part of that. Treatment of comorbidities. Rarely do we see someone with just COPD and no other medical history. Kind of goes without saying, but we're seeing diabetes. We're seeing obesity, certainly. Hypertension. It's sort of the triad that goes along with everything. And yes, you can have a COPD patient that is cachetic, that has muscle wasting, but they're still going to probably have some other comorbidities that are very commonplace. Nutrition's a big deal. You that are newer to respiratory care, there's only a few on the call, no doubt. Most of you are very experienced and have been doing this a long time. One of the first things I noticed as a new therapist many years ago is these patients would have candy in their room, but I never really saw much food. Well, they can't eat a big meal, especially if they've got hyperinflation or an increase in residual volume because their belly gets full, doesn't allow the diaphragm to fully excurt, and they can just maintain that shortness of breath. So they're just like quick, easy calories that are not always that healthy. And they stay dehydrated many times because they're just taking in the minimum to survive. And they're in a state where a lot of them can't take care of themselves in the end stages of disease. Now, everything shown here, these all depend upon the general clinical condition of the patients, of course. And at the bottom, we can't forget always smoking cessation. Can you take everybody's word for it that they've stopped smoking if they come in with yellowed facial hair about the mouth? I don't know that they've quit smoking. If they've got the fresh pack of cigarettes or the chewing tobacco, have they stopped tobacco use? I don't know. So sometimes a tactful approach is easier said than done, but it should be approached nonetheless. So to the left is the most current 2023 update to the management cycle of COPD. And on the right was the prior iteration of a nice summative chart that plots intervention class or type with specific intervention. And although the right-sided chart was pulled from the prior 2019 guidelines, it still remains current to date. And you can see pulmonary rehab is there, smoking cessation is there. In some cases, that lung volume reduction surgery really changes a patient's life. And we have other more technologically advanced options I mentioned the one-way valve, the pulmonary stents, when you have certain disease processes that mandate such interventions. Not trying to inundate you with too much information, but I want to give you your money's worth. So here is a nice summative chart in a case where a patient's symptomology did not subside. So this gives great perspective as to the potential next steps in treatment and therapy. Notice on both sides, combination therapy is recommended, more than just one medication. You can see that on the exacerbation category side, that inhaled corticosteroids is added in at a certain point, as well as potential use of that phosphodiesterase 4 inhibitor, that PDE4. And one of the most common on the market is roflumilast, also known as daily res. Some people call it dolly res. I thought this was pretty good. Many years ago, I did a stint in pulmonary rehab, and you would see some of this banter going on in the pulmonary rehab circles, everybody bragging on their device. You know, that camaraderie makes a difference. Well, let's get down to the granular portion here. Let's look at a few simple cases to put into practice a bit of what we've discussed so far. And all of these are patients, but the names have been changed to protect their identity. So we have very limited information here, for instance, and it's more realistic that you would probably have an entire workup, or at the very least, some summative clinical history. But let's do this exercise to further emphasize some key points. So you've got a gentleman that's 64 years old, claims to be a non-smoker, presents to the pulmonary outpatient clinic after he's referred from his primary care physician. Nothing too outrageous here. Patient complains of worsening fatigue overall, with the chief complaint that he's short of breath. Upon exertion, he has this nagging dry cough. You can see that this patient isn't elderly per se, but he is of a certain age that likely has allowed significant exposures to particulates and debris over his 6+ decades of life. Do recall that smoking history is not an absolute necessity to consider a COPD diagnosis, although smoking is still the most common risk factor. Environmental factors other than tobacco can contribute to COPD. This patient's fatigue in general could be an indication of a plethora of underlying issues, comorbidities. But keeping with our limited time today and the goal of today's topic, his fatigue could likely be due to overall poor sleep quality from the coughing. Just generalized hypoxia, albeit mild. When you have a deoxygenated state, your end organs are starving for oxygen. The persistent dry cough could be worst case scenario, yes, such as cancer, but a persistent cough, even with no expectoration or any increased secretions, could be a sign of underlying general mild inflammation and obstructive disease. The patient certainly would need further diagnostic evaluation, such as spirometry, and I would recommend a pre- and post-bronchodilator. A chest x-ray would be very good, maybe even a 6-minute walk test. I would want to know more details about his overall clinical history, but his resting sat, maybe his sat with mild exercise could be helpful, maybe even an EKG if so inclined. Do recall, before we move on to the next more detailed case, that a FEV1 to FVC ratio of less than 70% post-bronchodilator, this is the so-called gold standard for diagnosis of COPD. Of course, clinical history, symptomology, etc., must be considered before COPD diagnosis could be definitive. Now, one last thing here. Certain patients may be found with pre-COPD or PRISM, also known as that preserved ratio impaired spirometry, and they are at risk for developing airflow obstruction over time, but not all of them do. So let's look at Ms. Sanchez. You that have been a clinician for any amount of time already recognize this looks like your typical COPD patient. She's 55-year-old female, longtime smoker, history of acute myocardial infarction. She had a CABG, 3-vessel CABG. She presents to pulmonary outpatient clinic for a 3-month follow-up checkup. She reports recent hospitalizations for pneumonia. She seems frequent flyer, right? She admits she sometimes forgets to take her breathing medicine and is currently still feeling weak with a productive cough. I mean, this patient is at high mortality risk given the fact that she has a significant cardiovascular disease history atop her recent exacerbation for her COPD. And she self-admittedly is non-compliant. Let's look at her PFT. I know, warning, warning, numbers are coming, PFT time. I know this isn't a PFT-centered presentation, but let's quickly glance here and evaluate the patient's spirometry. Now, baseline pre-bronchodilator is shown to the left here, so let's concentrate on the left column. This is what the patient actually performed. This is what they should have done, in other words, predicted, and this is the comparison of the two, known as percent predicted. Now, for the right side of spirometry, also known as the post-bronchodilator or post-treatment evaluation, recall that improvement in FEV1 or FVC of at least 10% would be considered a significant response. Note that only a change of 100 mils as opposed to the typical 200 requirement, but with overall FVC, the percentage is the most important metric of change indication. And here, there is a 15 to 16% change or an increase in FEV1 respectively. So you can say with confidence that this patient had a positive bronchodilator response. But we can also say with confidence this patient has significant obstructive disease. So how do we know this? FEV1 to FVC ratio, she should have done 82%. She did 39. It's 47% predicted, less than half of what she should have done, but we're looking at absolute value only here. So she is definitely less than 70, coupled with her general clinical history, depending upon her MMRC score and her CAT. She is a gold category 3 for spirometry. Only a category 4 would be worse. And she's gold category 3 because her FEV 1% predicted is 47. So she's in that category 3. So this is Miss Sanchez chest x-ray, still on the same case. The lungs, you'll notice, are markedly hyperinflated. You can count down your ribs. I'll give you a little clinical nugget that wasn't in the learning objectives. Your widest transverse process here, notice the transverse processes of this vertebral body is always widest at T1. So this begins your first thoracic vertebrae and your first thoracic rib here. It's a good landmark. The lungs are markedly hyperinflated. You've got flattened diaphragms, particularly on the left side here. It's somewhat rounded on the right, probably because of the liver only. Bullish change in the left upper lobe. Notice I've got interstitial and vascular markings clearly delineated here. They're almost absent in this left upper lobe region. The heart has an elongated appearance. You can see it here. Very little right anterior border is present. You can just see the left anterior. And yes, this patient meets all typical criteria for COPD diagnosis, but likely is presenting per her chest x-ray with specific emphysema. Let's look at another short case, and we'll move quickly, running out of time here. Mr. Algohim. Immediately, you notice we have two potential significant risk factors, smoking and occupational history. Yes, most jobs per OSHA mandate PPE as indicated, but you'll find a large portion of workers rarely comply consistently, particularly in certain professions or environments. You can see from his CAT and his MMRC that he is a grade 3. So he is very, very sick. Here's Mr. Algohim's spirometry, both pre-bronchodilator, his baseline, and post-bronchodilator. Notice here that his actual FEV1 to FVC ratio does meet gold criteria for COPD less than 70. And there was really not a significant bronchodilator response, as indicated by less than a 10% change. In other words, neither FEV1 or FVC increased by at least 10%. Now, putting it all together in consideration of his clinical history and spirometry, along with subjective metrics, Mr. Algohim should officially be categorized as a gold 2 according to his spirometry, a grade 3 according to his MMRC, and a high indication of COPD-related impact to his quality of life, his health-related quality of life with that 33 on his CAT test. And consider he also has a recent history of exacerbations and a hospitalization. So putting it all together, you can see here the Group E recommendations compared to Group A and Group B. Group E, Group A, Group B. The groupings are dictated by the degree of exacerbations and that MMRC and CAT assessments. Now, we have limited time here today, but let's quickly overview the specific treatment strategies between stable COPD and COPD exacerbations. It's worth noting that there are so many different varieties of specific medications among the categories that only categorically mention are the ones here shown, okay? So you'll notice there isn't a great dichotomy between the two types of COPD patients shown here, but of course, exacerbations are treated a bit more aggressively and with a few added on adjunct therapies. Today's webinar timeframe won't allow us to do a deep dive into mechanical ventilation and some of the others, but keep in mind that non-invasive mechanical ventilation is a mandatory treatment in some exacerbative states when you have a DNI or DNR, but it's also a mainstay treatment for COPD exacerbations, as well as invasive when indicated for COPD. So just for reference, and so you'll have it at your fingertips at the conclusion of this presentation, here is the list of main bronchodilator types for stable COPD. You can see it's a plethora. And just mainly for reference, here's the list of anti-inflammatory agents for COPD, stable, only a reference. So quickly here, a long-term oxygen therapy is indicated for stable patients who have a PO2 at or below 55 and a SAT at or below 88. ABGs, I know it's always a back and forth on the question of whether we should get an ABGs, but notice it should be checked frequently to assure adequate oxygenation without CO2 retention or worsening acidosis. There's more to it than just oxygenation with COPD patients, as you're aware of. High flow should be considered as well as non-invasive, in addition to just oxygen therapy. And last but not least, some patients need admission to the hospital or higher level care, maybe an ICU, to be placed on mechanical ventilation. So in general, as we close here, this is the grand overview of COPD management. You can see that diagnosis is multifactorial as well as initial assessment consideration. The crux or framework for COPD management, again, is going to be proper and accurate diagnosis. Thereafter, symptom management and exacerbation prevention is the key. If you're interested in much, much more or so inclined, near the end of this year, the International Conference for Gold COPD is coming up. You can go to their website for more information. I want to leave you with some food for thought, directly quoted from the latest GOLD Guidelines comprehensive report. COPD is preventable. It's treatable. It's extensively underdiagnosed and misdiagnosed many times. And remember that environmental factors other than tobacco smoking can contribute to its presence. And it can start early in life, affecting even younger individuals. And I appreciate your attention and would love to take any questions you might have.